Welcome to the Texas Epidemic Public Health Institute's Grand Rounds for May. We present topics of interest in infectious diseases, and today we're going to talk about fungal diseases. So who is TEPHI? If you're joining us for the first time, we're a agency that's committed to keeping Texans safe and the economy strong by strengthening the capacity and resiliency of Texas communities to respond to future infectious disease outbreaks. We are housed within the UT Health Houston system, but cultivate a number of partnerships with other agencies and nonprofits, professional associations, businesses, other academic institutions, community organizations as well. And one of our programs that we want to highlight is our Pandemic Preparedness and Response Certificate. So this is an totally online, asynchronous, free for Texas residents, 4-course certificate. Although, to be honest, you can take any one of the courses. You don't have to complete the certificate if that's not of interest. But it builds up to a tabletop, a public health emergency preparedness and response course, which has a tabletop embedded in it. You can get CE credits in a wide variety of disciplines related to public health, I should say, if you're interested. You can connect with TEPHI, go to our website, and here are some of the things you can sign up for. Besides the certificate, we have mini courses, 1 to 3 hour courses in topics of interest in pandemic preparedness. Again, free to Texas residents, totally online, asynchronous. You can sign up for so that you get notified about our grand rounds every other month. We also have TEPHI talks that relate more to how the business community can prepare for outbreaks. And you can sign up for our free newsletter, I guess is the word, but it's called Lit Rep. And we scour the literature, the published literature, the gray literature for topics of interest in pandemic preparedness so that you can keep abreast of what may be on the horizon. So some housekeeping. You can click on that live transcript button if you want closed captioning. There's a Q&A link. If you want to ask a question, we'll take at the end. You will get a survey to complete, so to help us improve these grand rounds. So please fill that out. If you have topics of interest you'd like us to address in the future, please put them in there. This webinar is being recorded, and because you've registered for it, you will be sent a link to it. It's also on the TEPHI website in about a week. If somebody else was not able to register and interested in the topic. And speaking of topics of interest, our next grand rounds will be July 10th at 4 Central Time. And the speaker will be me talking about new and updated vaccines of global importance. So I hope you can join us. So our speaker today is Dr. Luis Ostrowski-Zeichner. He is a professor of medicine and epidemiology and the Memorial Hermann Endowed Chair at UT Health Houston. He is the vice chair of medicine for healthcare quality and the division chief at the Division of Infectious Diseases for the McGovern Medical School, part of UT Health. He also serves as the chief epidemiology officer for the Memorial Hermann Healthcare System. Again, if you're not familiar, that's part of UT Health Houston. And in his spare time has consulted for both the FDA and the CDC. He's published over 200 peer-reviewed articles and actively pursues research in translational and clinical areas in medical mycology, transplant infectious diseases, healthcare epidemiology, and antimicrobial stewardship. So welcome, Dr. Ostrowski, and I will stop sharing so you can.
Thank you so much for the very kind introduction and the invitation to present today. One thing that doesn't show up in my CV very often is that I'm actually an adjunct professor of public health at the school in the Department of Epidemiology.
How could I miss that?
and it is my pleasure to be able to do events for the School of Public Health. So today we're going to be discussing fungal outbreaks and the lessons we've learned. And Kathy, do you want to give me a thumbs up if you can see my PowerPoint? Perfect. All righty. So these are my disclosures. I do consult with pharmaceutical and diagnostic companies every so often. And we're going to start with a little bit of an introduction to fungal outbreaks. As any outbreak is defined, we define an fungal outbreak as an increase in incidence of a fungal pathogen over the expected incidence in a specified time, place, or population. This actually assumes that you're doing some sort of surveillance that will allow you to identify this increase in incidence. But believe it or not, we don't actually have this like command center looking at outbreaks for fungal infections in the United States. We do have the mycotic disease branch, which is an amazing place. But most often we are cued to these outbreaks because of local physicians noticing patterns. So this is a theme that you're going to notice. That's very important. We do need to hear from the people on the ground telling us that they're noticing an unusual pattern of disease. Per CDC, again, the mycotic disease branch, they used to investigate 1 or 2 outbreaks per year in the United States, mainly candidemia outbreaks in NICUs. But in recent years, they're investigating about 3 to 6 fungal outbreaks per year, which talks about the increasing incidence of this disease. As you're going to see in the lecture today, that you can sort of group fungal outbreaks into 3 common patterns. Those are healthcare-associated transmission outbreaks, environmental events leading to fungal disease in the population, and contaminated products, materials, or medication out there in the community or in healthcare settings. Most of the times, these outbreaks are monomicrobial, that is one organism causing the outbreak, but you can also see polymicrobial disease, particularly when you're talking about contaminated products, material, medication. Those are a lot harder to detect sometimes, but they do happen. And as I'm going to show you today, these outbreaks are very, very tightly associated with increased mortality, increased cost, and very, very high liability, including jail time for people that are involved in this outbreak. So we're going to be showing you the big impacts of this unfortunate events. So we're going to start with healthcare-associated transmission. And of course, when we're talking about healthcare-associated fungal outbreaks, we need to start with Candida auris, which is the bug that's on the news all the time and in everybody's mind in healthcare. So Candida auris is Candida species that was first described in the literature in 2009, cultured out of the ear in a Japanese patient. That's why it's called Candida auris, from the ear. And as many new Candida species, it was reported, and everybody said, oh, it's interesting and get buried in the literature. And after 2009, we started to hear of little outbreaks of a cousin of Candida auris, Candida hemuloniae, particularly in Asia. And eventually, when they look back at those strains, they realized that they were being misclassified as Candida hemuloniae. They were actually Candida auris. We started to hear about more outbreaks in South Africa, Venezuela, and eventually the UK. And that's when the alarm sounded throughout the world. And why is Candida auris so important? Because not only can it be multi-drug resistant, this is the first time we're talking about a multi-drug resistant fungus when we're discussing this particular yeast species, but it transmits very efficiently in healthcare settings. So this is what I affectionately call the Acinetobacter of the yeast world. You can have an MDR organism easily transmitting in hospitals, and that's why this organism is so important and you hear so much about it. But before talking specifically about Candida auris, I want to sort of explain how does Candida transmit or behave in hospitals. So we used to think that Candida is primarily an endogenous infection. That is, you're colonized with your own Candida flora, and you have sort of a breach in the normal barriers to infection, like having a catheter going from your skin directly to your heart, or a big surgical intervention in the abdomen, or a big accident that bursts your gut and things spill into your peritoneal cavity, translocating your normal flora. So that's kind of how we used to think about Candida. It's your own bug that translocates. Outbreaks used to be very rare in hospitals. They were primarily reported in neonatal ICUs. And again, this is a population that is going a lot of interventions with catheters. The babies have immature guts. There's translocation. Necrotizing enterocolitis in this population is very common as well. And eventually, most of the outbreaks that were happening in the NICUs were related to healthcare workers. And you can actually culture Candida in artificial nails. And that's why we're such sticklers about not wearing artificial nails in the hospitals. But also in 2009, we decided to look at our epidemiology of candidemia here at Herman Hospital. This is a poster that we published in 2009. And as you can see here, from 2007 to 2009, we had 107 cases of candidemia, pretty typical demographics for Houston and for Candida. A little bit male predominance. We had Hispanic patients. Our Apache 2 score mean number was 18.9. Long length of stay, long ICU stay for our patients. Crude mortality, 26%, which is, again, pretty typical for Candida. And what we started to notice, which was pretty interesting, is that not all of our Candida cases were in the ICU, which is a typical epidemiology. We noticed that about a third of them were happening in the regular hospital floors. About a tenth of them were happening in the intermediate ICUs. Our sort of species epidemiology, pretty typical: Candida albicans, glabrata, tropicalis, parapsilosis, cruzi, which is what 99% of Candida species are in the United States. And we did find that 72% of them were susceptible to fluconazole. One isolate was resistant to echinocandins back then, which is kind of the new backbone for treating candidemia. But the most interesting finding in this poster was we did some DNA fingerprinting, we called it back then. This is a system that allows you to see the genetic interrelatedness between your Candida strains. And we found that 26% of our isolates were not unique. They were related to another hospital, and another isolate in the hospital. And when we grouped them, we found that we had 11 little clusters of candidemia with 2 to 4 isolates, mostly Candida albicans, 4 isolates of Candida parapsilosis, 2 little clusters of fluconazole-resistant Candida albicans. So this actually told us that we unknowingly had transmission of Candida species within our hospital. And FYI, we tried to publish this in a journal, and people didn't believe us, and it never really got published. This ended up as a poster at ECAC. Flash forward, I told you about the UK outbreak for Candida auris. This is outbreak reported in 2016. And this is an outbreak that occurred in a hospital in London called the Royal Brompton Hospital. Small hospital, 296 beds. The physicians there noticed a case of Candida auris in a sternal wound in a patient with cardiothoracic surgery, which was unusual. They had never heard of that bug there in that hospital before. Within a week, they had a second case, and eventually they ended up with 50 cases within 16 months. And all of the isolates were genetically identical. So this was a transmission event. This is the epidemic curve, and as you can see here, they started with 1 or 2 cases in April, 1 or 2 cases in June, and before you know it, you have this like massive amount of cases. This outbreak necessitated the closure of the surgical ICU. Um, they cultured everything they could in that hospital, and they found it in the floor, they found it in the bed rails, they found it very importantly in a temperature probe that was used very commonly to measure the temperature in the ear of the patients. So that was supposed to be the source. And again, this outbreak rang the alarm throughout the world and made us start doing surveillance for this organism. And it's here to stay. In the United States, we have pretty high transmission here in Houston, primarily in the long-term care setting, in our LTACs and skilled nursing facilities, rehab places, nursing homes as well. But every so often we have incursions into acute hospitals, and this is one of the main concerns we have in infection control right now. So this is the prime example of a healthcare-associated outbreak of fungal disease. Let's move on to environmental transmission, and we're going to start with my favorite outbreak of all times. This is a large outbreak of histoplasmosis among American travelers associated with a hotel in Acapulco, Mexico. So very interesting outbreak. Spring break, 2001. CDC got reports of hundreds of college students returning from spring break in Acapulco, coming up with a febrile illness, with flash pneumonia, some mortalities as well. And CDC sends a team to Acapulco, Mexico, to investigate this mysterious illness. And they start getting reports back from the States, hearing that this is histoplasmosis. Most of these kids are testing positive for histoplasma. They do field work with their Mexican counterparts in the Mexican Department of Health, and they narrow down most of the cases to a particular hotel, which we're going to call Hotel H. If you buy me a beer later, I'm going to tell you which hotel that was. And eventually, again, this is important. So field work, they send a team down to the hotel to investigate. And the team notices that this is like a huge hotel, the huge tower, and they only have 4 elevators. And the elevators are noticeably slow. They're really, really slow. And we have very busy college kids wanting to party. So they don't wait for the elevators. They're taking the stairs all the time. CDC team finds a bat colony in the stairwell in this hotel. So what was happening is the kids were taking the stairs. They were getting exposure to histoplasmosis through the bats, and they're coming down with massive amounts of cases. And again, this is a disruption of the environment where a bat colony is established in a hotel. And what happens is we get spring breakers with histoplasmosis. Another really interesting outbreak of disease occurred in Joplin, Missouri, 2011. This is, if you recall, one of the biggest tornado outbreaks in the history of the United States. Joplin was particularly affected with this massive Category 4 tornadoes. And eventually, there was the massive disruption and destruction in Joplin, and CDC gets a report of several patients with mucormycosis. CDC goes and investigates, and all of the cases are being caused by this mold called apophimyces, which is one of the mucor-causing molds. And they find that they're genetically identical, and they find it in the environment, in debris, and a lot of contaminated wood with this organism. So again, this is an example of how a weather event disrupts the local ecology. Apparently, this fungus is very frequently found in this area. And with human injuries, with debris, we get an outbreak of mucormycosis, which is very unusual. And very close to us, and this is Hurricane Harvey. So if you recall, Hurricane Harvey is one of the most devastating hurricanes in the Gulf Coast history, with pretty much the drop of 2 feet of rain in the Houston area within 2 days, massive flooding throughout the city of Houston, And as we started to watch the news report and seeing that water was being basically drained from houses, the water line was all the way up to the ceiling. People were going into their houses, and we just saw this horror pictures of mold everywhere in the walls, in the ceiling, mattresses that were all moldy, people just pulling out sheetrock and mattresses into the street, etc. We got very concerned that Houston is a medical city. We have a big medical population here. People were getting exposed to mold in these dwellings. So we invited CDC to come and do a study with us, looking at the incidence of invasive mold infections in the Houston area. And this is a before and after design. We looked back at 4 major hospitals in the Houston area, looking at standardized definitions for mold disease in the few months before and the few months after Hurricane Harvey. And as you can see here in this graph to the right, we did see a little bump of the cases of mold infections that was self-limited for about 2-3 months, and then it went back to normal. So again, this is an incident where a weather event caused a lot of damage and displacement. Immunocompromised hosts were being exposed to massive amounts of mold, and we did document that there was an increase in the incidence of invasive mold disease in hospitals in Houston. And I do want to recognize we have a few of our collaborators here today, particularly the staff of the Laboratory for Mycology Research, who did most of this work with me. We're going to move on to products, materials, or medication. And we're going to start with another very famous outbreak that occurred in the early 2000s. Ophthalmologists in the United States started to notice a weird occurrence of keratitis in patients that wear contact lenses. And once the culture started to come back, they started to notice that all of them were growing fusarium. CDC gets called in to investigate, and they find that most of the cases are related to not a particular contact lens brand, but a particular contact lens solution, renewed by Bausch and Lomb. They start an investigation, and they find that they don't actually find any contaminated lots from the factory. But when they're culturing the contact lens cases, the solution, they're testing positive for fusarium. So this is an outbreak where the solution is not being contaminated at the source, but rather it's a solution that has nutrients that are actually conducive of fusarium growth, and fusarium is growing in the contact lens cases at home. And again, this is ancient history. Before we had a lot of disposable contact lenses, people had to keep their contact lenses for long periods of time and wash them, etc. And again, the Bausch and Lomb solution is pulled from the market, and the outbreak is resolved. And again, this was a great moment in medical mycology because ophthalmologists learned to use voriconazole with us. We learned to diagnose this with ophthalmologists. This was a lot of multidisciplinary work that led to the mitigation of this outbreak. Another really interesting outbreak, this is related to materials or linens in this case, basically. University of Pittsburgh notices an increasing incidence of mucormycosis in their transplant patients. Pittsburgh is one of the biggest transplant centers in the country, and it's very alarming that a lot of their transplant patients are getting mucormycosis. So again, they do an investigation locally and in cooperation with CDC. And the first thing they find is that the transplant unit had negative pressure rooms. And which, when somebody built that unit, they were very well-meaning, having negative pressure to isolate patients. But the last thing you want in an immunocompromised patient is negative pressure, because you're basically sucking in air from the hallway into your room. And they did find heavy contamination of mucor in the carpet right outside the unit. So the theory was that the negative pressure was bringing in spores from the contaminated carpet. They changed the pressure differential. They changed the carpets into floor, which is what we like in hospitals now. And they were still having cases of mucormycosis. They started to culture everything, which is the reflex that we have when we have outbreaks. And they do notice that the linens in the unit were positive for mucor. So the theory was that maybe the linens were being folded when they were wet, but they got moldy and they were being utilized in the patients. But eventually they realized that that wasn't really the problem. There were a high number of spores of mucor in the laundry itself. And somebody took a little field trip, went off to the roof and looked at the air handlers for the laundry, and they noticed this incredible water damage that you see on the roof next to the intakes for air in the laundry. And they remediated the roof and the outbreak went away. So again, this is an example of an environmental or building disruption that contaminates healthcare materials, in this case is linens, that causes an outbreak in a transplant unit. And then we need to talk about one of the biggest fungal outbreaks in US history. This is again mid 2000s, 2012, when physicians in Michigan start to notice that there's a group of patients that had steroid injections in a variety of places, mostly spinal, but some of them in joints. And they were coming to hospitals with invasive mold disease. They culture the organism, and it turns out to be Exerohilum, which is one of the black molds, we call them. And all of a sudden, we have hundreds of patients in the Michigan area with spinal abscesses and infected joints with Exerohilum. Again, CDC gets called in and they start investigating the cases. They see that most of these cases are presenting a little bit late, around 30 to 60 days after their injection. They're presenting with spinal abscesses. They're presenting with meningitis. They're presenting with, again, joint infections. And they're able to trace all of the cases to a medication that was compounded in a pharmacy. The problem with this pharmacy was that it wasn't really working as a compounding pharmacy, which is supposed to compound a medication for a specific patient when a doctor orders that medication. What they were doing was that they were compounding this medication in massive amounts ahead of time, ahead of the orders, and then they were marketing their services to the doctors, de facto working as a pharmaceutical company, manufacturing medication without really FDA supervision. And when the FDA and CDC went in there, they found that they appeared to have sterile conditions for compounding their medication and all, but in their compounding room, they found a leaky boiler that it had, like a leak on the floor, and they were able to culture it, and they found the Exerohilum that was an identical match to all the patients. So we have basically illegal manufacturing of drugs that are being used in sterile spaces together with steroids, which is the recipe for one of the most devastating mycology disasters in US history. Again, we have hundreds of patients that developed these infections. A few of them died. Many of them are still to this date being treated for these fungal infections, disability, fibrosis in the spine, etc. And I was mentioning that some people go to jail, and eventually these people not only got sued with civil penalties, but there was a criminal trial for this people that ran this pharmacy, and they ended up in jail. So again, these are the consequences of contaminating medication with Exerohilum. And for the last part of our lecture, we're going to flash forward to 2022 and 2023. When we started to hear late in 2022 about cases of atypical meningitis in Durango, Mexico. So I was in a meeting in November 2022 in Mexico when I was pulled to the side and somebody told me, hey, have you heard of what's happening in Durango? And I said, no, what's happening in Durango? And we were basically informed that there were many, many women who were delivering babies in 2 hospitals, and a few weeks or months after delivery, they were coming with atypical meningitis to be seen by a neurologist. This was an outbreak that was noticed by the neurologist together with infectious diseases. This seemed very, very familiar to what happened with Exerohylum, so we immediately started to think about contaminated medication, and eventually they found that these women were undergoing epidural anesthesia, and the practice in Mexico is to use morphine together with the other medication that's used for the epidurals. There was a shortage of morphine in Mexico, so the practice for the anesthesiologists here was to keep a vial of their morphine with their stuff and use it as needed for their patients. And as I was told, a single vial of morphine would be enough for several hundred patients to receive anesthesia. So they were not tossing the morphine because there was a shortage. They were just going around with their little bag and doing anesthesia in this poor women. As you can see here, this is the epidemic curve. We have one case here, one case there, and once the outbreak is identified and an alert is put out, then we start noticing dozens of cases. And once we put out an algorithm on how to manage these cases and how to diagnose them, mortality goes down to almost zero. Again, this is a collaboration between the clinicians in the field, in this case, neurologists and ID doctors, with public health that put out guidelines very quickly to identify more cases, treat them early, and it turns out that early treatment in fungal infections is of paramount importance, and this basically affects the course of an outbreak. They were, to my knowledge, never able to culture the organism from a closed vial of morphine in this outbreak. 3 patients tested positive for Fusarium. They were able to culture it, most fortunately post-mortem. And eventually the Mexican Reference Diagnostic Institute developed an in-house PCR for Fusarium, and they were able to use that for additional case finding and for monitoring the patient. So they actually implemented the PCR for monitoring the course of the disease and being able to stop the antifungals. Again, this had an attack rate of about 20%, and the mortality was very high in the 50% range. Then we hear in March 2023 that CDC notices a posting in the EIN. This is the Emerging Infections Network, which is kind of an early version of social media for epidemiology nerds. A physician in the Texas-Mexico border posts that he's noticed 2 very unusual cases of meningitis in patients that traveled to Mexico and receive epidural anesthesia. So CDC quickly says, hey, we know about these other cases in Durango. Let's investigate here. And then they start case finding and data gathering, and they realize that there's more than 2 cases. There's several women who are going to Mexico, getting elective surgical procedures, cosmetic, in 2 clinics in the city of Matamoros. So basically, they realize that all of the cases are coming from one of these 2 clinics. They work with the Mexican counterparts. Mexico closes those 2 clinics immediately. CDC on May 16 issues a level 2 travel health notice to avoid travel to Matamoros for cosmetic procedures. Then we have an HAN, May 17, and by May 20, CDC receives a list of all the patients who had surgical procedures in those two clinics since January. And they start working with state health departments to identify cases. So I was deeply involved in this outbreak. We, first of all, created a definition. And as you can see, we have what we call person under investigation, which are people that had a procedure in one of these two clinics, and we don't have any information about them yet. Suspected case are patients where we don't have any lumbar puncture results, but they have the signs and symptoms. Probable cases have abnormal CSF and maybe a positive fungus by PCR or a next generation sequencing. And for confirmed cases, we have to grow the fungus itself from CSF or tissue. And we ended up with 185 US residents who traveled to Mexico that were under investigation. And we ended up with 10 suspect, 10 probable, and 10 confirmed cases with a mortality of 8 patients when we close this data cut. And then we issued guidance for treatment and for monitoring of these cases. And as you can see here, Texas was disproportionately impacted by this outbreak. Most of the cases were seen here in Texas, and we had the opportunity to take care of many of these patients within the Memorial Hermann system, or UT Harlingen was the other place that took care of most of these patients. So these patients were presenting very late into healthcare settings. Most of them had symptoms that were starting about 20 days after they had the procedure. And as you can see here, days from procedure to hospitalization were 60 average, 2 months of a delay. And what was happening to these poor women is they were having mild symptoms like headaches and low-grade fevers. They were going to ERs, and they were being told, oh, this is most likely a post-lumbar puncture headache, because that's a known complication of epidurals. And they were getting, just analgesics and, hey, let's just watch it, etc. And unfortunately, the more delayed, the more chance for mortality in this disease. The earlier you treat these cases, the better they do. And as you can see here, most of them were presenting with the typical symptoms of meningitis, which are headaches, light sensitivity, nausea, stiff neck, and vomiting. We were eventually able to culture the organism here at Memorial Hermann for the first time. Again, unfortunately, on a patient that passed away. This is a post-mortem culture, and we were able to grow Fusarium solani. And unfortunately, we were able to collect a number of cases from Texas. And as you can see here, most of these were young women in their 30s getting tummy tucks and mommy makeovers, they call them. Time from surgery to admission was a mean of 38 days for the surviving patients, 58 days for the deceased patients. Talk about delay in diagnosis and mortality. All of the cases were really related to one of these two clinics, Clinica K3 and Riverside Clinic. And a lot of them, most of them had severe abnormalities in the CSF. We were able to detect Fusarium by DNA in 4 of them. And we actually found it in just gram stains in a couple of patients. And most of these patients were treated with steroids, EV drains, lumbar drains, VP shunts. So they require advanced neurosurgical techniques to really be able to survive. And eventually we found that these patients had a drug, an organism that was basically untreatable with the medication we were using at that point. So this is the antibiogram for the Fusarium strain. And as you can see here, they're resistant to azoles, which are the main sort of agent we'd use for CNS infection. high amphotericin B-MIC, which also indicates possible resistance, resistant to terbinafine, which is one of the last resort antifungals that we have. And very importantly, they were susceptible to fosmanogepix, which is an investigational antifungal agent, which we were able to procure as compassionate use. And the patients that received fosmanogepix did very well, fortunately. So these are the imaging findings in these cases. And as you can see, this is a disease that primarily affects the basal part of the brain, brainstem disease, with vasculitis and eventually aneurysms that burst, and that was what was killing these poor women. And this is pathology, and you can see this gelatinous mass in the brainstem encroaching on the blood vessels of the brain. And most of these women were dying of aneurysms and strokes. And you can just see the tissue invasion directly in the brain and the blood vessels by this organism. Again, we created guidelines for monitoring these patients very closely, low thresholds for repeat lumbar punctures, low thresholds for advanced neurosurgical techniques, EVDs, stents, and again, the main problem was strokes and vasculitis. So we work with an endovascular surgeons to help us maintain those blood vessels working. The source, the question was this linked to the previous Durango outbreak? Again, these were patients getting epidurals for anesthesia. They were using morphine. As far as we know, no one was able to find a vial with morphine with fusarium in it. But we did hear that the practice was similar in Matamoros to Durango, where the anesthesiologists have their own little vial of morphine, and they go from patient to patient to patient. This anesthesiologist work in these two clinics, and actually, I've been told that most of the cases were related to a single anesthesiologist, and people think that it is really a single vial that was contaminated. And again, the interesting thing is that there were no other cases throughout Mexico to think of a common contamination at the factory level. At the end of the talk, I do want to emphasize that working on outbreaks requires a standardized approach. You don't go, screaming outbreak, 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 and talking to the press immediately. You need a command center. You need somebody who's in charge, who has different specialists that work in their areas of expertise. So we typically have an operations person, planning, logistics, finance, communications, and we have doctors who are the medical. That's our role, is to be experts in medicine. But most of the time we do rely on public health and on emergency preparedness to deal with these outbreaks. This is a very nice reference you see here as to how to approach outbreaks in hospitals. At the end of the talk, these are the lessons learned. First of all, fungal outbreaks are becoming more frequent and severe. We described 3 patterns of fungal outbreaks: healthcare-associated transmission, environmental events with environmental transmission, contaminated products, materials, and medication. These outbreaks, as I've shown you in the examples, are high morbidity, mortality, and they cause very negative exposure to the people that are responsible for it. They do require a rapid response and a command structure to effectively deal with them. And I've shown you many, many papers today. And I think that's one of the key points, is that once you finish with your outbreak, you're really not finished until you publish your results, because that's how we learn and that's how we build the knowledge base to handle subsequent outbreaks. So we were able to use a lot of the experience with Exerohilum for Durango and a lot of the experience from Durango in Matamoros. So I do want to stress out the importance of publishing your findings. I'd like to thank the people at CDC, Cameron County, Mycosis Study Group, the UT physicians collaborators, our collaborators from Mexico, very importantly, laboratory for mycology research here at UT Health in managing this latest outbreak. And I'm going to close with my contact information and a very cordial invitation to join us at the Mycosis Study Group biennial meeting that's going to occur in September this year. This is the one-stop shop place if you want to learn about clinical mycology and network with mycologists. This is the place to be. And I want to again thank Dr. Tracy and TEPHI for the invitation to speak today.
Thank you so much. Go ahead and put your questions in the chat. I'm going to start with a couple. You mentioned at the beginning, at the end, about the increase in fungal infections. Why is that?
Well, there's at least two theories. One is that one of our favorite theories is climate change.
Yeah.
The world is getting warmer and the fungi are adapting to warmer temperatures and to being able to be displaced from their natural habitats and making into habitats that they were not really seen before. So that's one of the main theories behind Candida auris. Candida auris is a thermotolerant yeast, which is a little bit unusual. And obviously you saw Joplin and you saw Harvey. Those were weather events that are related to climate change. That's one of the theories. And the other theory is that we're also having a shift in medicine. We're dealing with more medically complex populations all the time. We're surviving cancer. We're surviving organ failures. There's more transplant patients. More people are on those interesting meds for their arthritis, for their IBS, IBD, etc. So we have an increasing amount of immunocompromised patients out there. And, you know, we do a lot of manufacturing for medical devices and medication as well. And we see more and more lax regulation sometimes.
Yeah, interesting. Yet one more effect of climate change. My other question is, you mentioned about the increase in multi-drug resistance. Is that due to the same reasons we see that in bacteria, overuse of medications?
Well, partially. I mean, at least for the hospital side, we do use a lot of azoles and a lot of echinocandins, and we definitely see a pressure within the healthcare setting for creating MDRs. But what's really interesting here is in the community, a lot of the pesticides that we use are actually fungicides because for agriculture, fungi are devastating, right? So we're starting to use a lot of azoles for pesticides, a lot of new fungicides that are actually related to the antifungals we're developing right now, which is very worrisome. So there's agricultural pressure for creating resistant aspergillus and other molds.
All right, we have a question from Dr. Del Close. Great talk, he says. And he's asking about a recent outbreak of blastomycosis in paper mill workers in Michigan with about 100 cases. Can you comment on that?
Yes, so that's another really interesting outbreak that occurred in Michigan late last year. All of a sudden, we hear about nearly 100 cases of wood mill workers with pulmonary blastomycosis. And unfortunately, George, CDC went in there and they did not find the smoking gun. They did find a lot of rotten wood, which is kind of a good habitat for blasto, but they were not able to find a single source or a clear reason why all of a sudden there was a massive spore release in that wood mill and caused this disease. Unfortunately, no smoking gun.
Okay, and I think we have time for one more question. Two more questions. How can we aim to prevent future fungal outbreaks, and how to expedite diagnosis when most clinicians may not consider fungi in their differential?
Yeah, so if you're old like me and you used to watch G.I. Joe in the 1980s, G.I. Joe the cartoon used to finish with a tagline, which was, knowing is half the battle. So really knowing about fungi and having it in your differential and knowing the history of this previous outbreaks goes a long way in identifying new disease very early on. So again, by the time we knew about Durango and Matamoros, we had the Xerohilum experience, and we knew that that was most likely the issue.
And I think one more. Have you seen fungus infections in pacemaker defibrillator? I can't talk today. Placements growing into the heart and up the carotid arteries.
Unfortunately, we have. Again, you can see pacemakers infected with mostly with Candida, but sometimes with mold as well, and those are almost always, unfortunately, lethal events. And it's very difficult to cure fungal infections that are involving devices. The device needs to come out. Mhm.
Okay, well, thank you all for joining us today. Thank you, Dr. Ostrowski, for a fascinating talk on fungal infections, and yet one more thing to worry about. But I guess no tummy tucks in the future for me, unfortunately. So please join us in May 10th for a talk about vaccines, updated and new vaccines, and then ones that are in phase 2 or phase 3 clinical trials. So thank you very much, everybody. Bye-bye.